out with us.
Definitely.
Yeah. So tell me a little bit about you. Like you're in Michigan. I just love to hear about your practice, like just wherever you'd like to start.
Yeah, I was born and raised in Metro Detroit, Michigan. Spent most of my life there. Went to undergrad at University of Michigan for undergrad and medical school. Go Wolverines! Big U of M fan. This year wasn't so great, but the ending was nice, and we have a bowl game coming up, so I think it could be good.
It's a great game.
Yeah.
Like that shocked the world.
Definitely. So happy about that. Outside the state, for most of my training, I did orthopedic surgery residency in San Francisco, California, spine fellowship here in New York at NYU. Right now, I'm an orthopedic spine surgeon, solely focused on spine, and I have a particular niche in treating spinal deformity, both in adult patients and adolescent patients as well.
Yeah. So when you talk about spinal deformity, can you unpack that maybe for someone that doesn't understand that?
Yeah, for the most part, when we talk about spinal deformity, we mean an abnormal curvature in the way somebody's spine is shaped. Most commonly, people know of scoliosis, which is a curvature either to the right or left in a patient's spine. And that's the most common scenario people develop. Another problem that we now see in spine surgery a lot is forward bending or kyphosis in spine. So as patients age, they can develop this, or from prior surgeries, they can have an atherogenic flat back syndrome or a very low degree of lordosis or curvature that helps them stand upright. And patients don't like that. Actually, quality of life outcomes with patients with significant sagittal imbalance, meaning a forward bend in their spine, are very poor. Those patients, they get fatigued quickly, they can't walk far, and basically they have poor quality of life.
Yeah.
Every day is a struggle. And I like helping those patients.
Because it's compensation, right? It's like because they're leaning over, that their whole body has to shift to basically walk and balance, right? It's like a...
Definitely. So basically they have no good foundation in their lumbar or low part of their spine.
Yeah.
That then stresses the joints above and below the spine. So the joints in the upper part of the back, and then also their hip, they get contractures in their hips and knees, and then makes walking very difficult for them.
Is this what you see? I think I know the answer to this. It's going to be no, or maybe the shopping cart. That's a different thing, right? That's the other way.
Yeah, no. Shopping cart is a forward bend. So oftentimes, when it comes to the nerves in the back that travel from the spine into the legs, they have to travel through small holes called foramen. And when people have spinal stenosis, which is a fancy word for narrowing of the nerves in their back, they try and do everything they can with their body to open up the nerve. And when you bend forward, those nerve holes open up, but it fatigues the body to a great degree.
Yeah.
And most of what I do as a spine surgeon, it's often funny, I say, we don't operate for back pain. We do surgery mainly for leg pain, when it's a neurological compression. When they have pain going down their leg, or in the neck, it's arm pain. Not for neck pain, but for pain going down the arm.
That was always explaining to maybe somebody doesn't understand, like if your arms hurt or your legs hurt, it's usually your neck or your back, right? Yeah. Relatively. Because of the way it innervates and the dermatomes and the nerves and all those types of things. When you're talking about how you treat deformity, I'd really love to hear about inner body and some, maybe some indirect decompression moves that you've been able to use in your practice.
Yeah, definitely. So historically, spine surgery is about making a big incision in somebody's back, removing all the bones and ligaments, and very large surgeries that result in long hospital stays, difficult recoveries, and higher complications. In the last decade or so, I would say that we've had a lot of change in the type of implants we use. And some of that has been what we refer to as inner bodies, or basically putting implants in the disc space. So we're restoring patients' natural alignment with smaller incisions, shorter hospital stays, and less complications. In order to correct somebody's deformity, you basically have to cut somebody's spine in half. Now, by going in with smaller incisions, usually from the front or from the side, we recreate their natural curvature with much smaller surgeries. So patients can undergo these surgeries with less complications and quicker recovery.
Have these new techniques allowed you, or maybe any of your colleagues, to take on more challenging pathology?
Yeah, well, it allows us to do less surgery with a better patient outcome. So, before everyone was a T10 pelvis, Right. Now we try and focus on what's causing them the leg pain, what's causing most of the deformity. And if it's a 1, 2, 3 level problem, that makes it a lot easier to solve for the patient. And, the inner bodies and cages have been around for a while, but we're now, with better research, we're finding better ways to use them. For example, when we go from the side, it used to be always just one incision from the side, a separate surgery on a separate day, and then going from the back. Whereas now we found ways to do it in different positions. And a lot of the companies have been advocated for, doing them from the side in a prone position, or basically the position we normally do spine surgery. So we can do their whole surgery on one day, potentially.
What has that procedure changed for you in your practice?
Yeah, I think it's led to better outcomes, in the patients, need less surgeries. And we can get the correction that we need without having to do a very morbid surgery for patients.
Yeah. Would you say that the deformity community, if you had to give it a range of like how much of it's still posterior driven approaches, like the traditional approaches, which are very much still working, but
Definitely.
they're not maybe the newest and latest in terms of those interbody and other ways to correct?
Yeah, it's hard to put an exact number. I would say maybe 70 to 80% of deformity surgeons are still probably majority posterior. And now there's maybe a 20, 30% of us that are trying to find ways to make it smaller. The unique thing about it is that we're all kind of coming together at meetings like this, at other conferences, to share data with patients, and share data with each other, in that there's a new way to do things, that if we can all figure out how to do it better, then as a country, as a world, we have better outcomes for patients.
That's right.
And that's what's the importance of these kind of meetings, is for others to share their data, to get the word out, and to share what's working and what's not working. Because we're not, we are limited in our abilities. Doctors, people think that we can do anything, but sometimes we don't. And, we do have failures. And that's the point about it, is that we share those with other physicians to help avoid them in future patients.
So speaking of other physicians, if there's like a like the primary physicians or other people that are referring and trying to find, what would you say to them? Like, who are you to their patients?
Yeah, I think they need to, if a person is beginning to have leg or arm pain, that's a good time to be seeing a spinal surgeon. For a lot of back and neck pain, the majority of that, I'd say 90% of that, is treated non-operatively. When a patient begins to have arm or leg pain, that's when we need to they should see a spine surgeon and somebody that, I always tell patients, you want to go see somebody that does a lot of whatever procedure that patients need. Well, that's what I tell to my friends, to my family. If anyone asks me what kind of surgeon, you want to go to the surgeon that has a lot of your problem. It's because they get the reps under their belt, they learn the tips and tricks to avoid complications.
Yep, 100%. So how do they find you? Like, how do they find that person that does what they need when they don't truly understand? If a patient doesn't truly understand what it is that they have, like they got.
Well, I think patients today are a lot more engaged in selecting their physicians.
Yeah.
And part of that is, social media, word of mouth, and when you're in practice long enough, people get to know you. And a lot of my referrals now come from other spine surgeons as well, knowing that somebody that wants to take on challenging cases, take on the revision. If they're typically doing very small cases, it can be daunting and intimidating. And then they find a surgeon that's willing to do those cases. A lot of surgeons are happy to send those patients.
So let me go one step further there. I love what you just said. So what is your practice? Like you said, I think you should just enjoy, maybe you even enjoy the revisions, or you get a lot of them sent to you. So like maybe just one step further, like, can you describe kind of like what you've been able to create in Michigan?
Yeah, so I'm based at a level 1 academic medical center at William Beaumont University Hospital. So I treat patients of all ages, but with a focus on spinal deformity. And so a lot of adult patients that had prior spine surgery, I would say, is a lot of my patient population. And then a lot of adolescent patients that have scoliosis or that big curvature in their spine.
Awesome. So when do you choose to use inner body? Like, is there some sort of an algorithm in your mind of like, this is the patient that, right? Like, or maybe when you don't?
No, well, definitely, it begins with a clinical evaluation, and a lot of that is looking at patients themselves. And then we have imaging. Imaging in spine in the last 15 to 20 years has changed dramatically. So anyone we're doing a spinal fusion on, we'll get a long-length standing film or a scoliosis x-ray on them to see what one part of the spine is doing to the other part of their spine. And then that allows us to focus and tailor surgeries for patients. And a lot of the time we are using patient-specific implants, whether that's customized rods or inner bodies that help correct that patient-specific problem. And we see with CTs and MRIs where to focus on.
It's fascinating, this whole world, and I'm sure this is great for these folks that are learning about you in terms of coming to you for care. Anything else you want to share around your practice or anything at all?
Yeah, I would say that we are constantly evolving in what we do. So that's why I'm here at this conference, because we always want to learn how to be better. And I think a surgeon that kind of doesn't think he's infallible is the best surgeon you can have. Somebody that's looking to help the patient in the best way possible and leveraging that network of surgeons.
What do you want your legacy to be?
That's a hard question to answer as a young surgeon, but I would say somebody that never gave up on getting patients at the outcome that they want. Sometimes my preoperative visits can be quite long, but it's really, I'm trying to hone into what is it, whether it's not about an x-ray or a CT scan, but what is it about a patient and their quality of life that I'm seeking to improve? And somebody that just has a dramatic focus on that. I mean, I do still love the, the outcomes part of spinal surgery, and that looking at what we're doing and research, and I still love being involved in that community. But ultimately what I care most about, somebody that's committed to getting the patient the outcome that they want. And sometimes I have to tell patients I can't help them. Some people think that surgery is always the solution, and I would say I spend more of my time actually calling patients they don't need surgery than they do need surgery. So that's something that people may not know.
Well, awesome, man. Well, this has been really a pleasure to get to know you. Thanks for sitting with us and spend some time here at the MTV studio, and really appreciate your time.
I appreciate it.
Yeah,
Very nice to meet you.
Yeah, you too.